questo è fondamentale leggere un libro. Per sapere un po' di più non basta seguire una lezione, ma ci vuole un po' di libro. Questo, come leggere un articolo che ti aiuta proprio a tutti le tipi di ricerche, diagnosi, terapia, associazione, etologia, eccetera, eccetera. Una cosa molto semplice e facile per prendere nel treno quando si fa un viaggio o qualcosa, è Sackett, che è un classico. Io non conosco nessun epidemiologo che non ha questo piccolo libro. Questo è già vecchio, questo è David Sackett. Questo non l'ho scritto su slide, le persone che vogliono vedere questo devono venire qui dopo e vederla. Anche questo è scritto in una maniera abbastanza semplice, in inglese purtroppo, e poi ci sono pure le cartoline dove sono scritto un riassunto delle cose essenziali. Allora, io penso che quasi ogni studente PhD in Amsterdam è cresciuto con questo libro, perché è fantastico, se lo consiglio veramente fortemente. Poi ho portato un'altra cosa perché Alessandro mi ha chiesto di parlare di cose che sono un po' troppo mischiate, troppe cose in una lezione, non si può coprire tutto. Allora, dopo, chi vuole sapere più di inferiority, superiority e equivalence trials, per forza deve leggere, oltre che dico io, perché lo dico molto superficialmente. E questo è un articolo classico che si può leggere, potete portare con voi, copiare, o lo mando a Alessandro così che la può distribuire. Non so, adesso faccio solo un'introduzione in questo tema, e l'ho fatto abbastanza basic perché è già tardi e se no non si segue più. Ok, vediamo. Adesso parlo inglese. Anche perché è molto imbarazzante per la registrazione dopo sentire il mio italiano abbastanza sbagliato, no? Ok, so always learning outcomes, that's what we need. We need to know actually what we need to understand from the lecture in the end, also to verify in the end after the lecture how much actually I did understand and how much I did not understand. So what you need to learn a little bit is, so what is actually a null hypothesis? What is an alternative hypothesis? What is an alpha? What is a p-value? What are the limits of a p-value? What does statistical significance mean? And what can I do with confidence intervals? And how should I interpret it? And that's all to help you, because if you read an article and you do not know these basic things, you will get lost. I mean, you don't know how to interpret anything of the paper. It's the essential that you really need to know. Because I know a lot of people that actually go to an article and only read the abstract. Worse, they only read the conclusions. I hardly ever read the conclusions. Because at the conclusions, the authors start drifting away from the evidence often, and often their conclusions would not have been mine based on the data that they result. They get over-enthusiastic and they over-interpret actually their results. So when I read an article, I read the objective. I most of the time skip the whole background section. Nice, but I just read the last sentence, which is typically the objective. I go to the methods. Okay, now does the method actually fit to the objective that I formulated? And I have then an opinion, yes or no. And then I look at the results, and I interpret the results. I interpret it. I don't blindly steer on what the authors say in the conclusions. However, to be able to do that, you have to understand the basics. And the basics I will try to capture in a quick flight. So, you need to understand this. You need to understand a little bit about effect sizes, and I will just mention few, but there are many more. But that's beyond the scope of this lecture. I will touch very shortly on non-inferiority, equivalence, and superiority. And then, Alessandra, it's your fault. I will talk also about quality, because that was in my assignment. And I interpret quality as the quality of the methodology of a study. So I will really fly over the main source of bias. Okay, let's start with hypothesis testing. And this is actually, well, how do I go from a research question to test actually what my research question is about, to test if there is, for instance, a difference between two therapies, or if smoking is really related to lung cancer. Now, let's take as an example a question that existed many years ago, and that was, does the order of birth, or the order in which children are born, does that affect the incidence, let's say, of Down disease? So just the order of birth. And I could also have phrased this in a more epidemiological way, saying, is the order of birth associated to Down disease? Much safer. Here I already talk about a causal effect. Now that's already dangerous. I usually express myself in is associated to, and I leave the option open if it is a causal relationship or not. Okay, let's look at some evidence. So here I have a live birth per 100,000, and what I see here is the birth order, and this is actually the cases per 100,000 with Down disease. And what I see remarkable, indeed, is there a causal effect? Well, let's see. So if it is the first child, and I compare it with if it is the 5th child of the same mother, well, here I see a lot more morbus Down disease, no? Wouldn't you agree? So, birth order causes morbus Down. I see some, no, nodding the head, no. But this is the danger, what you can do reading without reflecting. The authors present you an association, doesn't need to be a causal association, and you have to think twice, 3 times, 15 times, is there actually evidence that this relation is real or not? And if it is real, is it really causal, a causal association? Now what's going on here? Because it seems to be really an association, no? So what is this actually? Well, let's use the data and look at it at a different angle, which makes much more sense from a biological rationale. Always need for an association, thinking about, is there actually a biological rationale for the association that I see? Things need to make sense. Okay. So here we have the women that are less than 20, and at the other end we have women that are 40 years or above. And we look again at the incidence of morbus Down pregnancies. Okay, and now I see again. Okay, it goes up, there is an association. Now this makes much more sense from a biological rationale of what we know now. But years ago, we didn't understand the biological rationale very well. But this is maybe more what would make sense from a causal association point of view. So if we would depict it now like this, to see which of the association now is the real one, here I have, again, the incidence of the morbus Down pregnancies. Here I have the birth order, and here I have the agent. So it's a 3-dimensional plot. And now what we actually see, it is not the birth order that is causing morbus Down, but it is the age group. Well, the more advanced the age is, the more morbus Down you will have, independent of the order of the birth. Wow. So it's not the birth order, it is the age. Now, how do we call this in epidemiology? That you see something, you see an association, but it actually is not reflecting a true association. Well, that is what we refer to as confounding. Now, what is confounding? It's like misunderstanding an association. So, for confounding, you need three elements. You need an exposure, which may be well, I'll show that later. You need an exposure, you need an outcome, and you need a third variable. Now, what I have observed is this. But there is a third variable that I initially did not take account to. Now, the exposure needs to be associated with the third variable and needs to be associated with the outcome. But the third variable needs to have an independent effect of the outcome. Now, translated to our example, you have here the birth order which we initially only observed. We have the Down syndrome, but there is the third factor, which is actually the maternal age, which, yes, it is associated with the birth order. Well, the fifth child, well, then the mother has advanced in age already. And this one is independently associated with the Down syndrome. And actually, this is the one that has an effect on the Down syndrome. It's not really the birth order itself. So this is the confounded variable. Okay. Now this is just to name it shortly, but not to explain it all. To understand if an association is causal or not, there was a very smart guy, which was also Bradford Hill, that set up 5 main criteria to determine causality. And in a nutshell, that is, there needs to be a dose-response relationship helps you to determine causality. If the effect is stronger, you know, with age, it goes up, the relationship. Well, that is an indication that you may have a causal association. There needs to be a time order. If it is the age that is responsible for the down, well then, or it is a drug dose, the drug dose, then it has to precede actually the disease that comes later. It has to be specific, coherent, and consistent, and that is beyond the scope of this lecture to explain. If you want to know about it, Google Wikipedia and Bradford Hill, and it will tell you everything. Or even better, buy the book, and you can have fun with the explanations that are in there. Okay, now the basics. Hypothesis testing. It forms the basis for the majority of inferential statistical tests. What does that mean, inferential statistics? Inferential statistics, that means actually that you try to interpret the results. You try to deduct a relationship or an effect from the results. It goes beyond descriptive statistics. With descriptive statistics, you just try to describe a population. The age and the gender and the BMI index and the amount of cigarettes that they smoke. You just describe, but you don't say, okay, cigarette smoking causes or is highly related to a given outcome. If you go to that, saying something about the association, then you go to inferential statistics. And then you come into the framework of hypothesis testing. So, for hypothesis testing, you have 3 main characteristics. You have to formulate a null hypothesis. And by convention, we denote that with an H0. You have to formulate an alternative hypothesis, which is the H1, or you say A, whatever you prefer, that is the convention, let's say. And then you have to be aware of type 1 and type 2 errors. Now let's look what these 3 things mean. Starting with the null hypothesis. At the null hypothesis, we always say that there is no difference. That is the convention. So, we say there is no difference that an association exists between the variables of interest, or if we are talking about two different treatments, there is no difference in effect of the two treatments. That is the null hypothesis. You always deny that there is a difference. And remember that you will get the slides afterwards, so no need to write. So in this example, it means that our null hypothesis would be age above 40 does not increase the risk of morbus Down. I deny. That is the null hypothesis. Now, what is then the alternative hypothesis? Well, that is actually the hypothesis that there is a difference. The statement that we aim to prove, well, prove is a very strong word. We can hardly ever prove anything in research. We can just make it more likely there's stronger evidence for something, but prove is very hard. So the statement that we aim to prove by our study and analytical statistics, and it is typically the statement that a difference or an association does exist between the variables of interest. So here in our example, it means that age above 40 does increase the risk of morbus Down. That is our alternative hypothesis. So I have now two hypotheses, and then what I want to do is I want to reject the null hypothesis, and the data needs to allow me that, and it doesn't always do. So what does that mean? First, let's have a look at type 1 and type 2 errors. Well, these errors are the most common errors that we encounter in statistical testing. And if ignored, that really poses serious risk at the data and how you can interpret them. So what does it mean? And now, yeah, it does. Let's display it. So here we have the reality. So the null hypothesis that there is no difference, if that is true, they are not different, and if the null hypothesis is actually wrong, it is false, then the treatments are different. So let's see if this is the truth, and this is what we conclude. Here we conclude that the null hypothesis is true, they are not different, and here we say that the null hypothesis was false, we reject them, when we conclude that the treatments are actually different. Now here we say the same. Here we are in perfect agreement, so this would be a correct decision. Now here, the truth is that the null hypothesis is false, and we also concluded based on our results. So this is also a correct decision. Now we have actually two error zones, here and there. Here the truth is that the treatments are no different. However, we say that they are different based on our data. So this is an error. And this is what we call a type 1 error. And that is important to remember. And the type 1 error is denoted, and that's very important to know, denoted by the alpha. That is the probability of a type 1 error. So that is the first error to remember. And to reread every time you sit in a train and you have a lost moment. The second error is here. So if the null hypothesis is false, and actually the treatments are different, but based on the data of the study, I conclude that there are no difference. So I fail to recognize the difference between the treatments. That is what we call a beta error, a type 2 error. So beta denotes the probability of a type 2 error. That's the second error. Now what is of course the aim in statistics and research land? That is to keep both the probability of both errors small as possible. By convention, the alpha is set at 0.05. I say by convention, but it is not necessarily that you always have to choose a alpha of 5%. 5% for the alpha. No, it can be 0.01, 1%. And actually in clinical research, we have this weird now convention that it should be 5%. But if you go to different types of research, then the alphas may be way smaller than 5%, what they choose. And the beta is usually set at 10 to 20% probability for a type 2 error. Now, let's think again. If the reality is that the null hypothesis is false and the treatments are actually different, now, if I make a correct decision, we can say that that is the 1 minus the beta. And this is what we call power. So if you grab an article and they talk about the power of the study to detect difference, then this is what they are referring to. Actually, the power of the study to detect that there is a difference. And that is usually set to 80 or 90%. That is, if the researchers have done a sample size calculation. Because a sample size calculation that determines how many patients or rats or mice or whatever have to be included in a study is based on some common ingredients, which are the alpha, the beta, or the minus the beta, and the difference that you want to detect, for instance, depending on the type of type. So if the power of type 2 errors is simply underpowered, is too small to detect the difference. So type error is falsely concluding a statistical significant relationship does exist when in fact it does not. And it is referred to as an alpha, or the false positive, or false alarm, and there are many ways to refer to this. And most of the times the alpha is set at 0.05. And this is actually what you then come across when you read an article. They say the p-value is smaller than 0.05. That refers, and p-value I will explain later, but that refers that the p-value is smaller than the alpha, which is set at 0.05. And if it is smaller than 0.05, smaller than the alpha, then we would conclude it is statistically significant. If it is beyond 0.05, we would conclude it is not statistically significant. And the pitfalls of doing that we will see later on. So, in other words, the type 2 error, so that is failing to detect a statistically significant relationship when in fact one does exist. You're missing an effect. And that is referred to as beta, as a miss, as a false negative, and there are many ways to express this. And it is actually referring also to the statistical power, which I already said, and the statistical power is nothing else than 1 minus the beta, which is typically, if you do a power calculation, set to 80 or 90%. This I've already said. Now, what a researcher, by selecting actually the power for a sample size calculation in the alpha is, it should reflect on the consequences of an alpha and a beta error. It's like with diagnostic research, where you have to think about what does it mean to miss the disease, what are the consequences for the patient, and what are the consequences if I overdiagnose a patient, which would be a false positive result. Always think about the consequences. Okay, now, just grab the person that is sitting next to you and discuss in a few minutes only a research objective that pops up into your mind. Talk about an RCT, the research design. If that research question should be answered by an RCT or a cohort study. I don't know if you have a treatment in mind or an association, exposure. Define quickly a zero, a null hypothesis, and an alternative hypothesis, and discuss the potential consequence of a type 1 and type 2 error. And the time is going in now, and I will give you maximally 5 minutes. Go ahead. I want to hear a lot of noise because you're way too quiet. No, anche tu devi partecipare. Poi sheet numero 2, lei. qualche persona se ne vanno. Com'è andata? Allora, penso che definire le ipotesi 0 e questa alternativa va abbastanza veloce quando si è deciso che cos'è la domanda, no? Perché già formulare una domanda e scegliere il tipo di studi è già un passo che vuole un po' di discussione. Poi discutere le conseguenze degli errori, questo è forse un po' più difficile immaginare. Okay, switch to English again. Now we go to the next concept, effect sizes. So we've talked about the null hypothesis, alternative hypothesis, type 1 and type 2 errors. Now we talk about effect sizes. And now we refer to effect sizes to unstandardized ones and standardized ones. That's one way to talk about effect sizes. Now, what do we mean with unstandardized? Well, actually, we are just referring to the metrics for this. That means, for instance, if I want to measure a difference in weight, then I can express it in kilos. If I express it in kilos, that would be an unstandardized way to express an effect size. Now, I can also do that in a different way. I can do it in a standardized way. That means nothing else that you leave the metrics, the natural unit, let's say, how an outcome can be expressed. So a standardized effect size can be something like a risk ratio or an odds ratio or a standardized mean difference, whereas expressing it in kilos, we would refer to as just a mean difference, not a standardized mean difference, but a mean difference or a weighted mean difference. I keep the scale of the kilos. In a standardized mean difference, I would lose expressing the kilos. That means also to interpret the data, the effect size, if it is in a natural unit like in a kilo, I can immediately understand what is meant with it. The difference in 3 kilos is easier to understand than a standardized mean difference that is a number that I actually do not understand well. However, you cannot always express things in the natural unit, which here is the kilo. So let's look at an example. Now what you see here, this is from an RTT on knee osteoarthritis where they compare a technique, a lavage, a washing of the knee, compared to not only washing the knee but also snibbling a bit around in it, removing a bit of meniscus, losing a bit of cartilage, etc., etc. So a bit more extensive the intervention, and they compare it to placebo. Wow, placebo, that's nice, because that means a placebo, you do make a hole in the knee, which is the ethical board will already start to complain a little bit, but I like it. So placebo intervention, they act as if they wash something in the knee, but actually they do not. They do maybe a little bit of water in there that the patient thinks that it has the real treatment, but actually it is something that cannot be effective. So that's what they depict here. Even worse. So here you see a timeline. It is before they get this procedure, 2 weeks, 6 weeks, 3 months, 6 months, up to 2 years after the procedure. And here we see a mean, okay, so it's a mean knee-specific pain scale score. Well, just imagine that this is not this, but this is a VAS scale, a visual analog scale, you know, like a thermometer where you have to express if your pain is from 0 to 10, where 10 is unbearable pain, you can't stand it anymore, and 0 is no pain whatsoever. And that's how they express it on on this axis. Now you see at baseline they all have some pain, actually quite a bit of pain. It is the VAS is between 60 and 70 somewhere all, so they are comparable at baseline. That's already good sign for an RCT. And then you see some differences in the beginning, maybe. You have to, if there is really difference, you have to look at the confidence intervals. Actually, they are all quite together. But let's see, this was the debridement, that is the red one. It goes like this. The lavage, only putting in some water in the knee and flushing it out again. That is the blue line. Well, actually, this debridement and blue line are very close together. And here, the mean values for the pain in the placebo group is depicted. Now, that the mean values are on the lines. Oh, you see these 3 lines, no? And it is expressed in the original unit, the national unit, which goes, the thermometer goes, pain goes from 1 to 100 here. Okay. Now what I see here, these things, these depict the confidence interval. How sure am I that the mean that I see on the line is actually the real mean? The 95 confidence interval tells me, well, actually, 95%. If I would repeat the study, I would find the mean that is somewhere between, this confidence, between, the mean would be between here and here. I'm not that sure, actually. I observe it here, but it could also be somewhere here. Now, the problem is if these confidence intervals of these different treatments overlap, that means I don't have actually the evidence that they are very different, or different at all. Here in this case we see that they are all overlapping these confidence intervals. So there's really actually no evidence that they are different. I'm already actually telling you everything that is coming in the next slides. Because this slide was just to show a unstandardized outcome on the natural unit. But here indeed the authors make the correct conclusion that there is no evidence for difference in the knee pain. And they express it with the mean and the standard deviation in the text, but in the figure it is with a confidence interval. Okay. Now, what is then a standardized outcome? Well, standardized outcome would be, as an example, I take the relative risk and the odds ratio. Now, what is that again? Let's look at it graphically. So here I have, you are diseased or you're not diseased. You have no disease. And here you have the treatment or you do not have the treatment. Or, if we're talking about associations, causal associations, here you have the exposure, cigarette smoking, and here you don't have the exposure, you don't smoke. No? Now I put in little letters, A, B, C, D. Excuse me, I think you will miss everything if you still reasoning with the nice example. Okay, so if I put in the letters here, I can start using formulas that are standard. However, before we do that, be aware that Americans have different conventions. In Europe, we put in the disease here, disease and no disease. Americans sometimes put them in here and put the treatment here. Now, if you get that in an article and you just plug in your A, B, C, and D and do your calculations, you'll go all wrong. Also, always if you read an article, check if they depict such type of data in this way, if the disease is up here or up here. Okay. Now, assuming that we express everything with disease, non-disease, treatment, no treatment like this, and I put in my A, B, C, and D. Now, I can think about the risk in the treatment group, the risk in the treatment group. So I'm thinking in this line. Well, that is the EER, the experimental event rate. And that is calculated as the A divided over A plus B. So a value that would come here if you add it up. So the EER is A divided by E plus B. And that is the risk in the treatment group. Now, I can also calculate the risk in the no treatment group, in the control group. That is called the CER, the control event rate. And that is calculated by the C in C plus D, like this. These are the risks in these strata. The risk in the strata of the treated ones and the risk in the strata of the not treated ones. Now, what is a relative risk? Well, the word says it already. A relative risk is a risk ratio. It's a ratio of two risks. So what is it actually? It's this. A relative risk is the risk that you observe here, the experimental event rate divided by the control event rate that will be calculated here, C over C plus D. If you make a ratio of these two risks, you get your relative risk. That is the mathematical part of it. Now, if you are an English one, or a statistician, which often prefer to work with odds ratios, you would start dividing odds. Now, who knows again what is an odds compared with how we tend to think in proportions? Let's say if we talk about a proportion, then we'll say, well, what is the risk of being a cross, let's say that is the question. Well, that may be 3 out of 7. This is how we tend to think, no? In frequencies, proportions. Now, the English have a different way of thinking. They think in odds. And what is now an odds? An odds is 3 over 4. Contrast this over this. That is an odds. So an odds ratio is not a ratio of two risks, which would be thinking in this kind of thing. No, it is a ratio of two odds. We are not used to think in odds, which would be a ratio of this kind of thing. Now, in this example, it's the odds of having the disease or not. So the odds here is A over C, and the odds here is B over D. And the odds ratio is then actually the same as this, is A multiplied by D divided by B multiplied by C. This is the same, it's just another way of expressing it. That is the odds ratio. Now, if something is quite rare, then the odds ratio is a very good approximation of the relative risk. They are almost the same. If something is not really rare, then the difference can be quite substantially different. That is something good to realize. A lot of statistical techniques are made actually to estimate an odds ratio, but not all of them. Nice that I know how to calculate it, but what does it mean in words? What if I read an odds ratio in a paper, what should I be thinking then? You have to think the value of no difference would be is 1, let's say. If there is no difference between treatments, then relative risk would be 1. Now, the more it is away from 1, the bigger the differences are. So if it is above 1, it means that the treatment or the exposure increases the risk of an event. And that can be good or bad. That depends on how you have defined the event. The event can be mortality, but it can also be pain relief. Also something positive or something bad. So the higher, the bigger the impact. As an example, RCT showed that beta-carotene, which is a vitamin supplement, increased the risk of dying by a relative risk of 1.15. Now, what does it mean? Well, that means actually an excess risk of 15% in those taking the supplements when comparing to those taking a placebo supplement. That's what it means. And that is just the best estimate that we now have of the effect size. Another examples. Smoking is found to increase the risk of developing lung cancer by an odds ratio of 4.8. Now what does that mean, 4.8? Well, that means that on average, the smokers are 4.8 times more likely to develop lung cancer when compared to non-smokers. You see, I always say something compared to, because the relative risk and the odds ratio, they compare two different types of strata. Now, this is actually already quite an extreme example. The odds ratio of 4.8 is quite large. If it would be a relative risk, it's really large. And actually, in clinical research, we should get used to actually small effect sizes, because if you would really be able to assess an effect well with a large study, then yeah, especially in the osteoarthritis research, the effect sizes that you would find are quite small. You can relieve the pain a little bit, not a lot. You can improve the function a little bit, not that much. And that is unfortunately the reality. So if I find odds ratios of 4.8 or higher, I already get suspicious and have this urge to need to check actually how good the study has been done, and if maybe the result is a little bit overestimated, or maybe this is just by chance this high, maybe the study was too small to estimate this effect really well. There comes in precision, and we will also see. But first, let's look what an odds ratio or relative risk lower than 1 means. Well, that means that the treatment or the exposure decreases the risk of a given event, which can be good or bad. So, when referring to an exposure, this can then also mean that it has a protective effect. I mean, actually, vitamin supplements were thought to protect against dying, to diminish the dying. But in reality, there is no proof that they are working in a protective way. No, there is some evidence that they actually harm. Example, a cohort study showed that beta-carotene vitamin supplements decreased the risk of dying by a relative risk of 0.65. Cohort studies. Before in the example, it was about RCTs. This means a relative risk of 0.65, that 35%, 1 minus 0.65, there is a 35% reduction in the risk to die in those taking a supplement when compared to those taking a placebo supplement. Okay. The truth is, with relative risk and odds ratio and risks is, I can tell this to you, and Alessandro can tell it another time, and a lot of teachers can tell it another time. However, if you don't play with it yourself, you will never internalize the formulas. So, few minutes, and please calculate the risk in the treatment group, the risk in the control group, the relative risk, and the odds ratio. And I will give you this formula. No, I can't change this. Just plug in the number yourself. Just play with it. Okay. So. Sì, abbastanza piccoli. Guarda, sì. Però lo scopo è fare i calcoli e poi vedere che cosa esce, se è facile da fare e se si può capire, se rischia molto basso o no. Ok. Allora, the calculation itself is quite simple, no? If you have it fresh in mind. If I see you in 7 days from now and I ask you to do it again without giving you the formula, I'm sure that most of you will have forgotten. And that is problematic, because if you read scientific research and you read about the relative risk, you need to know what it is. And the same for the odds ratio. You need to know if the odds ratio is a good approximation of the relative risk in that study, yes or not. So you will only learn to understand it if you do these calculations yourselves and try to explain to yourself what these numbers mean. So look again at the handouts that you will get afterwards, look again in the textbook and try to understand what it all means. Okay, confidence intervals, an extremely useful thing. So what is a confidence interval? Confidence intervals express the confidence we have in a specific effect size. Because before on that line you saw the mean effect size as they were observed, the mean estimation of the pain. But that's just a value. Now how sure am I that that value is actually the value that indicates the pain? And there the confidence interval come in. It provides the range of values within which we are confident the true population estimate mean of a proportion lies. That is the official, let's say, explanation. And typically it is set at 95. So 95% I am sure that the true value for the pain relief lies within a range of 2 to 8, let's say. That would be a very large confidence interval. Okay. Confidence interval is calculated with some ingredients. And it depends also on the distribution. And that goes too far to explain. So, the standard error of the mean is used to calculate the confidence interval. The point estimate of the outcome is used in the confidence interval. And the degrees of freedom. No time to explain that, let's say. Usually, if it is non-distributed normally distributed outcome, then you have the mean value as you observe it. Let's say the pain relief in group A was 4, and you multiply that with a Z statistic, which usually is 1.96, multiplied with the standard error of the mean. The point estimate, you do it plus almost 2 multiplied with the standard error of the mean, or minus. And then you get this upper value and the lower value of the confidence interval, and that means you're 95% sure that somewhere between these two extreme values the true value lies. And the effect size that you saw on the line, that is the best effect size that the data suggests. The true value lies somewhere on that confidence interval. If you would repeat the study, the effect size may be estimated a little bit differently, higher or lower. So the 95 confidence interval can be calculated for any effect size, and it indicates you how precise the effect was estimated. It means that if you see a wide confidence interval, the conclusions you can get of the data are weaker. If you see a very narrow confidence interval, that means that you're pretty sure about the effect size, and you can make stronger inferiorities. stronger conclusions of what the data actually suggests. Now, confidence interval can cross a value that we refer to as a no effect value. And I've said before, for relative risk of a loss ratio, that is 1. So if it crosses the no effect value, that means what you have observed is not statistically significant, which means you have no evidence to conclude that there is a difference. So you have no hypothesis is true. And what it also indicates automatically, if you observe a wide confidence interval, that also means that actually the study that was looking at a given theme was too small. It was statistically not powered highly enough to detect any difference. That is also what a wide confidence interval tells you immediately. The study was too small to detect the effect. So what is this? Well, this is a graphical display of several studies that you see here. These are cohort studies. And here just some information of what type of patients were included. And it looks, in these cohort studies, the association is looked for between vitamin supplements and cardiovascular mortality. And here we see RCTs. And there are 4 studies, and they have these type of patients included in these RCTs. Now here, what I see here is an effect size. It is a relative risk. This is the no effect value of 1. This indicates there's no association between beta-carotene and cardiovascular mortality. And this is the best estimate for all of these studies. So it is here, 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 here. These lines are the confidence intervals, the 95% confidence intervals. So this is the best effect, but the effect may actually be here or there. Now, this is how sure we are. This is quite a large study, which I can deduct from the quite narrow confidence interval. Always be aware of how the scale is presented, actually. And I can deduct it from the fact that here the square is larger than the other ones. This is a larger study than this one, this one, this one, this one, and this one. It is weighted by the sample size. Here I can immediately see, and this is an error, this one should be more centrated, but this is a quite large confidence interval, which means, yes, this is the effect that they suggest that is the effect of beta-carotene on cardiovascular association, but I'm really not sure at all. It can maybe even here, the opposite direction. So it's too small to show me anything. This can be even due by chance that I observe this effect. And here it is again, a bit more narrow and a bit more sure, etc., etc. I will ignore this because this is a pooled effect, summary estimate of all these together. However, what I tend to see is in the cohort studies that beta-carotene reduces the risk. It is lower than 1. It reduces the risk of cardiovascular mortality. What I see here in the RCTs is all the effect sizes are on the right side from the no effect line. They are greater than 1. So what I see here is actually, it seems that if I exaggerate, is that beta-carotene kills. I'm exaggerating, but this is what the data suggests. Now here, it is a large study. However, the effect is small, which also has then in itself the risk that you touch upon the no effect line. Indeed, it seems this borderline significant or just not significant. I can't tell from here. Here, it is too small the study to be sure about the effect size. And you get the picture. However, no? Yeah. So what you can see, what is nice to see is actually, and we will touch upon that later, the cohort studies say one side of the story, but if you focus on RCTs, they tell you a completely different story. Ha, that's interesting. Later on, we will see why that is. But see how a confidence interval helps you to interpret the data? No? I am quite sure about an effect. It seems to be precise in this individual study. I'm not sure at all where the confidence is, where the effect size is laid. So if you read in an article, okay, the odds ratio is 4.5 with a confidence interval from 2.8 to 6.1. What does it mean? Well, it means the best estimate of the odds ratio is 4.5, and the lower bound of the 95% confidence interval is 2.8, and the upper bound of the confidence interval is 6.1. And we are 95% confident that the true odds of the disease for the exposed versus the unexposed lies between 2.8 and 6.1. That is what it means. I will skip this. So then the last bit here is statistical significance. And there are some fantastic cartoons on the web. Can my boyfriend come along? I'm not your boyfriend. You totally are. I'm casually dating a number of people. Yeah, but you spend twice as much time with me as with anyone else. I am a clear outlier. Oh, your math is irrefutable. Oh, face it. I'm your statistically significant other. Statistical significance. For an effect size to be statistically significant, the probability of obtaining a value of the test statistic, which may be a t-value or a z-value or whatever, it must be smaller than the probability to commit type 1 error. There you go again. The p-value has to be smaller than the alpha, what we saw before when I explained type 1 and 2 errors. So the probability p must be less than the chosen alpha, which is typically set at 0.05. Hence, statistical significance occurs when the p-value is below 0.05, if that is your alpha. If a statistical significant relationship is found, then we conclude that the observed relationship is too large to exist by chance alone. And if the p-value is beyond 0.05, we typically conclude that there is no evidence for the difference in effect. The finding is not statistically significant. And that was the example of the knees with the lavage, the debridement, or the placebo. Indeed, they concluded that they could not detect any differences. However, they also said exclude any clinically meaningful difference. So it is not all about statistical significance. You also have something like clinical relevance. You know, if my study is very, very large, I can even detect very small differences that have no meaning to clinical practice at all. Also be aware of that. You know? If I can detect a difference in pain on a scale from 1 to 10 of 0.3, but I get a lot of side effects from NSAIDs, NSAIDs for instance. Well, is 0.3 then, is that a clinically relevant difference? That is what you have to ask yourself. And I would actually say it is not. Usually we say that on a pain scale from 1 to 10, it is around 1. If the difference is more than 1 or more, then you have a clinically relevant difference. So that's something different than the statistical significance. P-values. Now, there is this tendency over the past years to stare blind on p-values. And actually, I don't like that too much. I really prefer confidence intervals. Stare at confidence intervals, but don't stare at the p-values. There are some limitations with the p-values. The absence of the evidence is not the same as the evidence of an absence. Well, people tend to misinterpret also p-values. I mean, if I see a study that has an effect size that is impressive, let's say an odds ratio of 5 or a relative risk of 5 even, I mean, that's already, if it is true, that's quite big. So I would check if the study is done well, but if I conclude the study was done really well, and a relative risk of 5, or even 10, even more extreme, that's massive. And if the confidence interval is very large, because the study was actually too small, I would not kick away immediately that article. I would be highly, highly interested to see if another study that comes along could confirm that effect. Now, it does mean something for me. The larger the effect size is, if the study is done well, the more convincing that is for me. You can't stare only on the p-value. It's only one bit of the story. It's not the single indicator of the significance, and it was never meant actually to be used like that. Also, something that happens is, p-value of 0.03, and one, there is a 0 missing here, is more accurate than 0.04. That's not that kind of relationship that you have with p-values. No, it is more that you have to look at the effect size and the confidence interval to have an idea of the precision, how precise the effect size was estimated. And there is not something like a dose-response relationship with these p-values. Another thing with p-values is, but also confidence interval, is the interpretation always the same? Well, you will see different situations. What you see here is the difference found between therapies on another scale. Here, 0 is the no effect value. Here you have a positive difference, and here you have the negative difference. No effect line. Here it lays on the positive side. The superior treatment A is found to be superior to treatment to another treatment. Here in this situation, you do not cross. You do cross the no effect line. Here you would say, well, there is no evidence actually that there is a difference. They may be equivalent. Here, the same situation. It crosses the no effect line. However, the effect size is maybe just by coincidence on the other side of the line. Here you see clearly inferior. The one treatment is clearly inferior to the other one. It's quite far from the no effect line, and it doesn't go beyond the no effect line. Here, the study is so extremely small, you cannot conclude anything. It's way too large, the confidence intervals. But you have to ask yourself about, is something superior? Is there evidence there is inferior? Is there evidence that there is treatment is equivalent or not inferior? And there you have to be careful with confidence intervals and p-values, because these questions are different. And the designs that come with this type of questions are different as well. Non-equivalence trials versus equivalence trials versus non-inferiority trials versus superiority trials. They have different type of research questions, different type, if they're done well, sample size calculations, and different type of handling of the confidence intervals and the p-values. And it's beyond the scope actually to go more into that. If you want to know more about that, then you should read it up. However, the vast majority of the papers that you will ever read is with the superiority hypothesis. And in the superiority trials is you try to demonstrate superiority of a treatment A over treatment B. Whereas in equivalence trials, you try to establish an identical effect of two therapies. And whereas the aim of a non-inferiority trial is to demonstrate that treatment A is no worse than a treatment B, but it may be safer. Wrapping up. If you read an article, look about their research objective. Try to realize what their null hypothesis and their alternative hypothesis is. Look what type of outcome they have taken, and if you would have taken the same outcome, is it actually patient-relevant outcome, or is it a surrogate outcome? Like if you are interested about fractures, but what they report is bone density, is that really an outcome that you would like to learn about? Or did they just choose it because it's easier to find an effect? let's say, but doesn't really say something about fractures directly. How are these effect sizes expressed? Am I actually looking at a relative risk or an odds ratio or something different? Yeah. What is the sample size of the study? Don't stare only at the p-value. Look at the sample size of a study. Try to understand what the power was of the study to detect any effect. Look at the confidence interval. How wide is the confidence interval? And we've seen, if it is very wide, I cannot make strong inference. If it's very narrow, I'm much more sure about what is going on. Confidence interval doesn't exclude the no effect value. That tells me something about statistical significance. If I know that something is statistically significant, your very next question should be, but is it clinically relevant? And a difference can be so small that it's actually completely irrelevant. Don't only think about one side of the think also about, does the confidence interval actually exclude that substantial harm can be done to the patient? Okay, no time for breaks. Okay, what is the time? Now, this was about the hypothesis testing. Now you can see that actually if you interpret a paper, that this is already what you have to think about. And this is not all. If you want to read a paper well and understand it well, you have to go even beyond. Seems to be much in the beginning, but once you have done it for several times, it gets easier and easier, and it gets a routine thing. It's like learning how to swim. I mean, if I look at my children now, already 3 years they have swimming lessons, and they are destroyed, and it is still an uncoordinated thing with the arms and the legs. No? It's like with the research. I mean, it's not, you can't learn it immediately. You have to practice and reread. You have to invest. But then once you've learned it, it's difficult to lose that knowledge again, which is good. Until you reach a certain age of 17, maybe. Yeah. So you have to go beyond, and that is where quality comes in. And I will just do a quick explanation. Quality. What does it mean, quality? Quality, what I'm going to talk about, it refers to the methodology of the paper. If it has been done in a way that it diminishes the risk of bias. I will slip quite some slides now. This was all about confounding, which you already heard. So bias, but what is bias then actually? Well, bias is a systematic error. It is any effect at any stage of the investigation or the study that tends to produce results that depart systematically from the truth. So let's look at it in a graphical way that's easier to understand. So let's assume that I'm going to measure the blood pressure of Alessandro. And I do it with a blood pressure cuff that I bought at Aldi. 10 euros. And I measure it several times, maybe 20 times or so. And this is the result what I get. Well, his blood pressure, the lower, the diastolic blood pressure, is around 90. That's my best estimate. But it is always, every time I measure it, it is a little bit different. And this is the spread what I see. Now, this is just the spread what I would expect you by chance. No? If you measure something over and over again, you will never have the same bullet. It will always be a little spread, and that's chance. Now, what if I would use a more accurate method to measure his blood pressure? And let's say I would do it intra-arterial. Now, if I would do that, then, and I would do it 20 times or so, and I find actually 80%, and I believe that this is the true value, and this is not. So what is bias then? Well, bias is this. It's the difference. It's a systematic deviation what I measure here, from the true value. The true value, my best estimate, is 80. What I get with the blood cuff is here is the blood pressure cuff is a 9, so the deviation is 10. Bias here is factor 10. That is how you have to look at the bias. It's systematic deviation from the truth, which is something else than differences, small differences that you just observe by chance. Now, bias occurs at many, many levels, and each research design has its own sources of bias. I really like this topic, but I will do it in 10 minutes and then we finish. Only for RCTs. So an RCT is what you see here. I have a study population. Say, okay, I will randomize you. You will get a placebo, and you will get in chirurgia, surgery. And then I look at pain relief. Now, I use randomization here. And why do I use randomization? Why is RCT the best design to avoid bias? That is because by using randomization, I try to avoid something that we call selection bias. I try to avoid confounding what we saw before, factors. What I try to do is to make a fair, clear, and valid comparison between two groups. I want any risk factor or prognostic factor that is related to the outcome of pain relief to be equally distributed in between the two groups. Before we saw that cohort studies said something about vitamin supplements on mortality, which was completely different from RCTs. And that is highly likely because the cohort studies could not prevent the equal distribution of confounding variables, prognostic variables. So these two groups observed in the cohort studies were not comparable enough. And for that reason, you found an effect in the cohort studies that is systematically different, that is biased, if you compare it from the RCTs. I believe more the effects that came from the RCTs. However, that is only true if an RCT has been done well. But because if you do your randomization wrongly, you do not use a good method, or you don't conceal, let's say, blind the randomization method well, then the RCT is actually not that much different or no different at all from a cohort study. And that is actually, we have evidence that that is also the truth. The effect size that come from cohort studies, if you compare them with RCTs that are not done in a good way, that the effect sizes are very similar. Whereas in an unfortunate situation like with the beta-carotene, the effect size from large RCTs can be completely different from what the cohort study says. That smells like a whole lot of bias to me. Okay, so randomization is to avoid selection bias. It is to assure that the groups are really comparable on important prognostic factors. Now that is maybe the main source of bias that you try to avoid. But now there is something that we refer to as performance bias, and that is all to do with blinding of the treatment. If I tell Alessandro, I'm going to give you a placebo pill, let's say, and I tell you, you will get the active pill, your expectation of the effect of the treatment will be different from his expectation. No? So, and that mental processes, placebo effects, are very, very important. In physiotherapy, I think a lot of effects from the therapy are actually placebo effects, especially if you talk about laser, etc., or magnet therapy. And I'm a physical therapist myself, so I think I'm allowed to say that. So by blinding a treatment, the patient, that guarantees you more that what you observe is a true effect and is not, there are substantial systematic differences between a group that knows that it gets a placebo and knows that it gets the active treatment, and expectations are different. But not only the patient is best blind, but also the physician. Because the physician that gives the treatment and knows that it's the active treatment may treat the patient also differently, may ask questions a bit differently, may give it extra advice is just subconsciously, but there is enough evidence that that has an effect. So also the physician, if possible, should be blinded. Now, if it is about surgery, that is impossible to do. So it's not always possible. If it is possible, it should be done. Also the outcome assessors. I mean, if I know the patient, I am the outcome assessor, and I know the patient got the experimental intervention. Yeah, and how is it with your pain? Is it better? I may, even without thinking about it, I may direct the patient in a certain way. Whereas if I know that the patient got the non-active intervention, the control intervention, I may not tend to do that. So I may have a systematic, different approach of how I communicate with the patient, which may really affect how pain as an outcome is measured in the end. Also the one that is doing the outcome assessment best is blinded. And that's almost always possible. Not always, but almost. And if you go even beyond that, actually you should also blind the one that is doing the statistical analysis, because if you do not, it may be, oh, let's do a subgroup analysis here, and let's do something there, and let's use that other method until we get something that is statistically significant. Not a risk. So these are blinding issues. This is the concealment of allocation and randomization method. Then there is still something to talk about, and that is related to the statistical analysis, attrition bias. Oh, yeah. No. I mean, a systematic review that is done in a good way will always have done a risk of bias assessment. That's why we call it. That means it is always made a judgment about these key elements, key sources of bias in the trials, or in the cohort studies, or in the case control studies, etc., etc. Because all of these studies have their own specific sources of bias. So done well, they have done it, and if they are reported well, because that's a different issue, then they have also depicted the results of their risk of bias assessments. And then you can look about what the individual trials, what the quality of these trials actually has been. Can they do it well? Well, often, and especially true for diagnostic test accuracy studies, the quality of the reporting of the individual articles is not good enough to make any good decision. And then you are in a difficult situation. Because it's not satisfying to say unclear risk of bias everywhere. So you really try to make a good judgment. Is there a high risk of bias or is it low? And there comes in the subjective element of quality assessments. I tend to be quite severe, so I tend to say quickly there's a high risk of bias, whereas other people, they have a lower threshold and say, well, for me it's still a low risk of bias. But there's excellent guidance on this, and that is in the Cochrane Handbook for Intervention Studies and Diagnostic Test Accuracy Studies. And there is a whole series of Gordon Guy and Holger Schunemann that is about grade. And grade teaches you not only about risk of bias assessment of the individual trial, but it also tells you then how to go even beyond that and then make a summary of the overall body of the evidence. So I look first at the 10 trials that I found and how good they are, but then put all the information together. And if I now want to say something about the quality of the evidence for outcome mortality, and I grade it as, and they have different levels for that. But it's difficult. It's very difficult. In some areas it's very easy because they have a good quality of reporting. And for other areas like physiotherapy, there we go again, well, there is a lot of room for improvement. So I'm really not sure about the design of the trials in a lot of cases, lot of cases, especially for the concealment of allocation, and that's so crucial, concealment of allocation. Okay. So I want to only say something still about attrition bias. Yes, and this is the slide that I need. Now, when you read an article, you will read something about intention to treat, modified intention to treat, protocol analysis, and as treated analysis. And I think that is the last thing I want to explain, because that is also very important to understand, because it can affect the effect sizes considerably, and it opens up the scope for a low, high risk of bias. So let's look again at an example. Again, an RCT. Here you have the randomization, and I randomize a group of patients to receive either a drug or a surgical intervention. Let's say I randomize 100 here and 100 there. And this is what happens. Now, of these 100 that were randomized to surgery, 91 actually received the surgery, and these 9 crossover, we call it. We cross over to the treatment arm, and they get actually the drug. They don't get the surgery. Now, here we randomize 100 people to receive the drug. However, what happens in reality is that 95 get it, 4 cross over to the surgery group, and 1 doesn't get anything. Now, there are a number of ways to analyze this. Intention to treat is you analyze it how you had it in mind, regardless of what happened. These 100 that you have randomized to receive drug treatment, you analyze it in the end. All these together, no matter what happened. So these ones are analyzed together with the 95 and together with this one. Well, how can that be? Because this one did not even get drug. Maybe I don't even have the last. I don't have information. Well, there are statistical techniques to handle that, imputation techniques. You try to really evaluate a complete set, and a true intention to treat analysis is 100 here and 100 in the analysis phase, and these hundreds are really coming from this arm, no matter what happened here. That is intention to treat. That is what we prefer as an analysis, as it is conservative. It may underestimate the effect, but we prefer to underestimate than to overestimate an effect. An alternative would be a per protocol analysis. That is, per protocol is, well, 100 I randomized to surgery, but actually 91 got it, as I had stated in the protocol. So I analyzed 91 versus 95. That is a per protocol analysis. That tends to result in a bit higher effect sizes. Not necessarily. If they are saying the same story, intention to treat in per protocol analysis, we have no problem at all. We are reassured that the effect size is probably a good one. If they tell a completely different story, then it becomes open to interpretation, and we tend to prefer the intention to treat one. The per protocol estimate can still tell you, well, it is maybe, if we would live in a perfect world where all the patients would do what the doctors say, or it can happen as the protocol said, this is actually what could, in theory, be achieved by the treatment. But in the real world, the effect size that you observe is in intention to treat analysis more realistic. But there is still a third way to analyze this, and that is called as treated. Now, what happens with an as treated analysis? That is, you really analyze them as they were treated. So, you treat these 91 and 4, you compare these patients in the as treated analysis with these ones. And you ignore this one. Now, this tends to be a logic way to analyze it. But that is a way you should not analyze it, because that is really bound to produce over-optimistic estimates. And why is that? It's not by chance that these people cross over. It's hardly ever by chance. There is a reason why they cross over. And the reason why they cross over is bound to have something to do with the prognosis of the patient. If it has to do something with the prognosis of the patient, it has to do something with the outcome. And then you get your scope of bias. Because what happens here is, well, they should get the drug, but Jesus, these four people are really young, and they have a whole life in front of them. They really have a good prognosis, and I am sure that surgery is the better choice for them. And that is why these four people has crossed over. That can be an explanation. If that is the explanation, having a good prognosis, well, then you undo actually what the randomization tries to achieve, making comparable groups. If you do an as-treated analysis, you are breaking the randomization. These people should have gotten surgery, and it was really the intent to give them the surgery, but they have deteriorated so fast, their health went down so fast, they could not possibly operate anymore, it was not adequate, and they crossed over, therefore, to the conservative treatment arm. Has to do with the prognosis. It is breaking the randomization code, it is introducing bias. So if you read an article that does an as-treated analysis, be suspicious. About the conclusion, be very, if they say this is better than, put a question mark. If they say intention to treat and a proportional analysis, if they provide both, look at the difference between them. No difference, no problem. Is there a difference? Look at the intention to treat one. And then you have the last option, and that is very, very often modified intention to treat analysis. Now, what is that? And that is a lot of analyses are actually modified. They say, well, anybody that was randomized was really analyzed in the final statistical analysis if, and then a couple of conditions. They had at least one follow-up, if they had at least 3 doses of the drugs. That's not intention to treat. That is putting out some patients. And if getting rid of these patients has to do with the prognosis of the patients, there we go again, we have a scope for bias. Yeah? So these are the main elements that are important for RCTs. Randomization, selection bias. Blinding, performance bias. Blinding of outcome assessors, detection bias, and adequate statistical analysis to avoid attrition bias. That are the main. But if you are interested in cohort studies, there are different sources. If you are interested in diagnostic test accuracy studies, there are different sources of bias, and you have to study on that. Okay, questions? I have some literature in the end. Oh, yeah. Come facciamo, Alessandro? Giri tu, perché il professor Costantino ha detto che lui la gira, ma così che loro hanno tutti i slide. Va bene. E così, alle diapositive. Sì, e poi ci sta pure il mio indirizzo email, solo per le cose urgenti e importanti mi potete contattare. Qualche domanda? Allora, lo ringrazio tantissimo perché abbiamo le 6:10 e siete rimasti, allora complimenti tantissimo e grazie.